Evening, doctors. I am Dr. Namra Sheikh, associated as a medical advisor with Emcure Pharmaceuticals. It gives me immense pleasure to welcome you all on this digital platform for another exciting session on no thrombosis workshop series, which is an acute ischemic stroke. It gives me immense pleasure to welcome our course director for today's session, who is Dr. Richa Poria, sir. Just a second, I'll share my screen. Is my screen visible, Manish?
Yes, yes.
Okay.
Yes, visible.
Okay. So it gives me immense pleasure to welcome our course director for today's session, who is Dr. Richa Poria, sir. He is the director of at Sayadri Hospital at Nagar Road and HOD at Sayadri Hospital. He is the first neuro. He has set up the first neuro ICU and a neuro intensive care of Pune. Sir has been a pioneer in thrombolysis treatment for stroke. He has the credit of delivering more than 300 public lectures and workshops on stroke. He has been the member of ISA and the different organizations. He is the founder of the Pune Stroke Group. He has been the ex-president of the Society of Neurosciences Pune. Sir has been the principal investigator for multiple stroke trials and has been awarded as the health icon by the Times of India group. We welcome you, sir. Thanks you for being on board today. I would now like to welcome Dr. Pramod Krishnan, sir. Sir is working as a consultant neurologist and epileptologist. He is also the HOD at the Manipal Hospital in Bangalore. Sir has a credit of a gold medal. He's received gold medal in DM Neurology and the Best Outgoing Student Award in Enhance. Sir is a certified specialist in stroke medicine. A few areas to name for his special interest include epilepsy, sleep medicine, multiple sclerosis, neuropathy. Sir has a credit of more than 29 publications in national and international journals. We welcome you, sir. I would now like to introduce the moderator for today's session, the second moderator, who is Dr. Meenakshi Sundaram. Sir is working as a senior consultant neurologist at Apollo Hospital, Madurai. With over 20 years experience in neurology, Sir has presented many papers at various prestigious national and international forums. Sir has received the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology at Lucknow. Being part of different international clinical trials, with being the primary investigator, Sir has been the editor of the South Asian edition of the book Practical Neurology and also contributed to many books on neurology. We welcome you, sir.
Thank you, ma'am.
Our next moderator for today's session is Dr. Parul Dubey. She is working as a consultant neurologist at Manipal Hospital, Goa. She has been awarded gold medals in pharmacology and general surgery and received a distinction in biochemistry as an undergraduate student. She has also been associated editor of the book A Clinical Approach to Neurological Disorders. She's been faculty in various national neurology conferences. She's also contributed to the most prestigious reference book for neurology specialities, with headache as a subsection, Yearbook of Neurology and Neurosurgery. She has also contributed chapters to different books included in Elsevier. Credit of more than 20 publications in national and international journals. I welcome you, Dr. Parul Dubey. Thanks for being on board today.
Thank you. Thank you, Dr. Namra.
So we have two eminent speakers today who will be discussing their cases. So our first speaker for today's session is Dr. Prateek Sharma. He is working as a consultant neurologist and chief of stroke unit at Bansal Hospital, Bhopal. Having an experience of more than 70 years in neurology, he has also established the first stroke unit in the city and has successfully performed more than 50 successful IV thrombolysis. He has expertise in neurophysiological testing and latest neuroradiological investigations. He's also been a part of IAN, IAP, IEAS, and ISA. He has contributed to different chapters in a book published on the occasion of International Headache Conference at Delhi. He's also contributed to modules which are mental status examination, neurophysiology of memory, and aphasia for the Elsevier Clinical Learning Program. We welcome you, sir, today.
Hello, am I audible?
Yes, absolutely audible, sir.
Good evening, everyone,
Yes.
especially. Good evening, Dr. Chapuria, and good evening, moderators. Yeah.
So without much ado, I would like to hand over the session to none other than our course director, Dr. Richa Poria, sir.
Yeah, good evening all, and very warm welcome to all of y'all. And I'm very, very happy to see three of my very dear friends as moderators for the first time, really, at least on this show. Dr. SMS, Dr. SMS means Meenakshi Sundaram from Madurai, and Dr. Pramod Krishnan from Bangalore, and Dr. Parul Dubey from Goa. And I know them very well, and they are extremely good neurologists. And more than that, they are extremely good friends and human beings. So, about this program, we've been running it now for 1.5 years. And I must say that, there's lots to learn from each of the cases which have been discussed. And we go back at 9:30 or quarter to 10, enriched with new knowledge and new insights. And I'm sure a lot of the audience also benefits a lot. And we've had a very good coverage and very good audience participation in these last 1.5 years. And I really find that this program is really very good, and it has a lot of teaching points for us. And I welcome Dr. Pratik Sharma and Dr. Manish Sharma and Dr. Varun to the show. And who is going to start first? SMS, could you say a few words?
Hi, good evening, everyone. If moderator allows, I can start early if possible.
I'll just ask the moderators. I'll just ask the moderators to put in a few words before we start.
Dr. Richa Poria, sir.
Yes.
Can I introduce Dr. Varun Rehani before we start?
Yes, yes, of course.
Yes.
Yes, Dr. Namra.
So I would like to welcome Dr. Varun Rehani on today's session. as a speaker, he will be delivering case presentation. So sir is working as a consultant neurologist at the BLK Hospital, Delhi, with his primary area of interest being stroke, headache, multiple sclerosis, and demyelinating disorders. He has won different prizes at different for poster and paper presentations. He has certification in multiple sclerosis. He has the credit of more than 5 publications in national and international journals. We welcome you, sir, today. Thank you for being on board.
Thank you, Namrata.
Thank you, Dr. Varun. Welcome to the show.
Thank you, sir.
May I ask Dr. Meenakshi Sundaram to say a few words, and then followed by Dr. Krishnan and Dr. Parul?
Thank you, Emcure, for having provided me with this platform to be with
Little
one of
loudly,
our mentors.
SMS.
Thank you very much, Emcure, for having provided this platform to be with one of our mentors, Dr. Ichapuria, sir. What we learn every month from No Thrombosis, he teaches us every day in our Demands Forum. So every day is No Thrombosis for us there in our forum. Thank you, sir. And it's always said that, trials and big trials will teach you something, but something more is to be learned. It is from, cases. Case reports give us more insights into this. I'm very much waiting to learn from the 3 eminent speakers today and from my eminent moderators. Once again, thank you, MQ, for the platform. Waiting for the presentations.
Dr. Pramod?
Yes, sir. Thank you, sir. And thank you, Emcure, for this opportunity. So it's so good to see more and more neurologists practicing stroke intervention actively. We have lagged behind for decades compared to other specialties in not owning this field and taking it forward. We've left it to radiologists and others to do it. So I'm happy that the speakers today, I can see that they're very young and they're into stroke intervention. And I hope more and more of us, our colleagues, our juniors, it becomes part of our DM program. It becomes an integral part of our DM and DNB programs. So I'm hoping that we get to see more such presentations from neurologists, and I hope to learn from today's cases.
Yes, Dr. Parul?
Thank you, Emcure, and thank you, sir, for having me here as a part of this team. Last time also I had learned a lot from the cases, and today also I'm hoping to learn a lot from the cases being presented. So really looking forward to the presentations now.
Yeah. Could we start? Who's going first? Dr. Pratik?
I'm ready to start.
Yeah. I think you start, Dr. Pratik.
Yeah, thank you, sir. Thank you.
Are you being able to share your screen, sir?
Yes, some time. Just sharing.
All
Take some
right.
time.
Yeah, sure.
Thank you again, Emcure, and all the.
Put it on full screen.
Yeah, I'm just putting it on full screen. Yeah, it looks everything good.
Yeah.
Yeah. So thank you, everyone, and Emcure for providing me this opportunity. Not much of ado. I will start with the case. This case looks important for me to discuss with all the esteemed faculty, because this is something first time in stroke we have done so. It's in a pediatric stroke, came to us around a year back, and we see it's totally something new for us, and we have gone ahead whatever we feel right on that period of time after a thorough discussion with the team. So actually, it's around a year back, this 15 or 14-year-old guy presented to us in mid of December. She was a known case of myocardial heart disease and mitral stenosis and post MVR in 2017. Bioprosthetic valve was there, and she was on antiplatelet since 2017, and everything was going well till that's go after that afternoon. When she presented with sudden onset left-sided weakness, she came from school and developed that weakness. She came back around three from school around 1 or 1:30, and she came to us around 3:30 with weakness for last few hours. So that has been worsening for some period of time. Somehow, because she was supposed to be on anticoagulation, so initially neurosurgeon was one called in emergency, and they got the CT scan done, which is not showing any kind of bleed. By the time almost 3 hours has been passed, then I have been called. When I examined that, she was conscious but looking drowsy, and everybody's saying that initially she was much more conscious. There's left-sided dense hemiplegia with left facial weakness and dysarthria. If I was by that analysis around 2022. So this was an initial CT, which looks normal, but we can appreciate there is a dense MC sign is visible there. This is first CT we got it done. When we have not done the thrombosis because she came into window period, but we are not very sure because we have not thrombolized any patient with less than 18, and there is no guideline regarding same. So we were not sure to go ahead with that, and keeping in mind that there is history of some heart disease, there may be some cardioembolic source may be there. So I'm not very much sure about the IV thrombolysis. So I discussed with my intervention radiologist that can we go ahead with thrombectomy? Are you ready? So he said we can do a MRI, so we have a better idea which kind of vessel we can is going to be occlude, which looks like dense MC sign. So get the MRI done, and this is the MRI is showing the almost caudate putamen is getting infected, or some part of frontal lobe is getting affected. So, but because by this time is running, so we arranged everything in the cath lab and shifted the patient to cath lab. And during the time we got the routine blood test done, which looks like normal. So we advise family about that. We are not sure about the intravenous thrombolysis because there is no recommendation regarding same. So we explain them about the thrombectomy, all the risk, prognosis, and benefit and of the procedure. We explain them that there is not much of incidence of pediatric stroke, and there is not much of data regarding the treatment with intravenous thrombolysis versus thrombectomy versus antiplatelets. But the family was very much supportive and says, sir, if you feel that this is the best treatment option is there, then we go have the mechanical thrombectomy. So ask our interventional radiologist to do chip in, and he done the thrombectomy using the solitaire and suction device, and patient withstand the procedure very well, but develop hypertension during the procedure and post procedure, requiring the inotropic support for 1 or 2 days. Initially, first day she was very drowsy, and we were skeptical, see what is happening. So we got the inner CT scan done on that night only. So that is showing the almost same thing, hyperdensity in that caudate and putamen external camper area and there's MCA area, but nothing, we were doubtful about that she might have a bleed or something like that. So nothing is there. She stayed for 1 or 2 days in ICU, for a few days in stabbed in ICU, and for the 7 days. And by the time she was discharged, she was walking all alone, and it was very well. Her ice tube has been out. She was accepting orally, so everything has gone very well. And she was discharged after discussion with the cardiology and CTVS person to on oral anticoagulation. She has been advised because the repeat echo is showing the severe mitral stenosis, and that she may need to undergo the mitral valve replacement, which she undergone after 2 months of in the follow-up. So this is the same. So this is the patient, and everything has gone well. We have just gone through the little bit literature. What is the data says? What is the recommendation, or is there any kind of SETA data to support? So there is not much of data available regarding thrombectomy in pediatric stroke. There is always doubt. This the published in 2019. There is a systemic review, which is also says there is not much of conclusive. There is level C evidence regarding same. And similarly, NIH's studies show that there is not role of thrombectomy is uncertain in acute ischemic stroke in pediatrics. Similarly, the guidelines from AHA and other from JNS and all the stroke and vascular, there is not much of data. Nobody's sure what to do and what has to be done. There's only few case series, few case studies are there, and everybody decide on the basis of case to case. There's no recommendation till date because there is a paucity, because no study has been done. Only recently, even regarding intravenous thrombolysis, there's not much of study. Only one study, which is called TIPS study, is done by NIHS recently. But again, there's some difficulty in recruiting the patient. Similarly, what is the data regarding from India? So this is the only study I can find it out from the Narayana Heart Institute from Bengaluru, which they have published a case of 5 studies, 2 from the MCA, 1 from the basilar, and 1 from the intercarotid artery, and all of them showed good recovery. So this is the only data I have. So we were very happy that we have done first time in Central India. So we published in the local daily also that patient has done well and improved. So this is the whole experience, and I feel that this is very something good to discuss with all the group. So thank you.
Hello, Dr. Pratik.
Yeah. So
yeah, Dr. Pramod here.
Yes, sir.
So did you also review the data regarding thrombolysis in these patients in pediatric population?
Yes, sir. I have just we have reviewed that there is not much of data available. As I said, there is a study called TIPS study, thrombolysis in pediatric stroke by NIH. But again, there is some not very effective because funding was an issue. There is also a doubt regarding the thrombolysis because there is a high level of basically tissue plasmin activity inhibitor in the pediatrics, and there is also not sure about how much weight, how much dose should be given regarding because they have a different totally hemostasis kind of level. So whatever study we have seen is been decided on the case to case basis. Nobody is sure how much weight dose should be given. Even who has given is then given on the basis of per kg kind of weight. So we are not sure, and I'm not very comfortable doing that interventional thrombolysis, especially keeping in mind the cardiac illness she has. She might have an electrode that were gone anyways. But whereas in case of mechanical thrombectomy, we are sure that we are not going to do any kind of harm if patient develop the hemorrhagic conversion, which is a possibility in intravenous thrombolysis, which is not much the case with mechanical thrombectomy. That's why we gone for mechanical thrombectomy.
Yeah, I agree with you. Not enough data, though there are some case series where they've done for pediatrics thrombolysis, and the outcomes were not bad. So, but as you said, there are no formal guidelines to help us in this situation.
Yeah.
So even if you had thrombolized, probably you wouldn't be wrong. And you didn't thrombolize and went for mechanical thrombectomy. It has worked very well for this child. And there was fortunately a large vessel occlusion that could be tackled. Yeah, so it's a very scant literature within the country. I think very few people have done it. So I would commend you for this.
Thank you. Thank you very much.
Dr. Meenakshi?
Sir, first, congratulations, Dr. Pratik, for this wonderful achievement, really, and putting in the paper also. I mean, that creates a lot of awareness.
Yeah.
We should congratulate for that also. That's one
Yes.
thing. Now, I have a strong belief, I have learned from Dr. Ichapure sir also. One principle we follow is that there is no excuse for not giving IV lysis. So as Dr. Pramod sir was saying, why not give IV lysis to them? It doesn't do any harm in my opinion. The reason why pediatrics were not included in this is not because of this reason. The reason is that pediatric strokes may be of multiple mechanisms. It may not be the atherosclerotic mechanism which we talk about or the RHD. Here the clear-cut RHD is there. So it was behaving like an adult stroke only. So we could have just gone ahead and would have lysed it also. I feel we could have gone and lysed it also. It's my personal view. I take from others also. Nothing harming doing that. It was basically a very large stroke. Even in the dense MCA which you showed, on the right side there were a lot of hypodensities that were evolving. That's this one was. What was the aspects in that patient actually? Should
So
be large core aspects. Yeah.
Yeah. So we have not checked it, sir. So it's a long back case. So I have not checked the aspect score. I need to talk to my radiologist. right now, I have no idea.
So anyway,
But
it's for
it's
high
on,
risky patient
yeah,
only
that,
and for high.
yes, sir.
Why was the
That's
patient
what
on aspirin?
she was on bioprosthetic wall, sir. So valve has
But we
replaced.
don't give
You are
aspirin
back.
for, do we give, sir? I'm puzzled about that. Why was the patient on aspirin? Huh? Do we give that, sir, actually? Because bioprosthetic, you don't have to give anything, I
Yeah,
thought.
yeah,
That's what my
yeah. That's
understanding
what my
was. And aspirin doesn't.
that's what my but serious person from who they got it somewhere in Mumbai, and they said please continue with the aspirin. This is the even I was saying, because most of the patient who was on bioprosthetic valve gives they require antiplatelet for a few months only, not for a long period of time. But she was on aspirin.
For the first 3 months, they require
Yeah, yeah.
anticoagulation. After, they just don't do anything. That's the
Yes.
importance of putting an bioprosthetic. These are two puzzles.
Yeah.
Anyway, thank you. Wonderful. Publish it also, sir. Thank you.
Okay. Thank you. Thank you for the appreciation.
Dr. Parul?
Yes, sir. It was a really wonderful case, and I would have been, if this case had presented to me, scared of IV thrombolysis also, looking at the size of the infarct. And of course, now that we know age is just a number, of course, we are not that scared about IV thrombolysis. Uh, just the other day on Man Group, there was a 100-year-old man thrombolized. So, yeah, maybe I agree with Meenakshi Sundaram, sir, that probably IV thrombolysis, yeah, but I would have thought about it a lot, because a few times I have lost patients with strokes of this size to IV thrombolysis. I don't know how everyone's experience is here, but so doing a mechanical thrombectomy, I think, yeah, look safer here to me.
That's what I feel, that this looks both safer and lesser chances of developing the hemorrhage. So, and fortunately, with the grace of God, that my intervention radiologist was ready to do that. So, if we would have said no, then we have to get the option of intravenous thrombolysis. So, that way it works. So, good for the patient, and she has shown the good recovery. So, everything looks good now.
Yes.
I have some, I agree with what Dr. Meenakshi Sundaram was saying, that, the trial was done in 18 to 80 or, beyond. They never took patients. That doesn't mean it doesn't work. It doesn't mean that you cannot do it. And this pediatric stroke, there are so many causes. There's sickle cell anemia, and there's PFO, and there's this. But, this is pakka embolic stroke coming from the mitral valve. Probably the patient had atrial fibrillation, and there was a clot in the LA or in the LA appendage, and that embolized into the brain. So it behaves like a routine stroke. So I don't think you should worry about age in this case. And to say that there is no data, I mean, that doesn't mean that you shouldn't do it. There isn't data. Because there isn't data, it's not in the guidelines. Because the guidelines will only come when you have a RCT done. And, it can come to level 1 evidence if there are multiple RCTs done. So obviously, in Western countries where these trials are done and we are just following them, there is no RCT for pediatric mitral stenosis, prosthetic valve or whatever, bioprosthetic valve. There is no study. And suppose this patient was 20 years old or 25 years old, which is common. I mean, we don't think twice. And I see no contraindication for IV thrombolysis in this case. And I am a quite avid advocate of IV thrombolysis followed by MT if necessary. Because many times, and on this forum also, we have had innumerable cases that 30-40% of them respond to IVT, especially with tenecteplase. I have a affinity for tenecteplase for these large clots in the MCA. And many times we do find that the clot dissolves and the patient improves. So I would definitely give benefit of IVT to this patient. And yes, if they don't respond and you can give tenecteplase immediately and see in the next 10, 15 minutes if he doesn't respond, then take him up for MT. I have nothing against MT. I mean, MT should be done if they do not respond to IVT. But surprisingly, many of them do. Literature says 30, 40%, but I think it's even more. And in a resource poor country like us, I think, the cost factor is huge and the benefit is huge of doing IVT. And of course, if they don't improve, go ahead for MT. And also, I see no reason for you to do an MRI. The CT scan is there. It shows a dense MCA sign. The MCA is occluded, and it seems a pretty long clot, definitely more than 8 millimeter. So that's enough. You don't need to see the infarct. I mean, there is a mismatch between the CT scan and the clinical picture. The NIHSS is 22, and the infarct has not come, and it's only 3.5 hours, and we are losing valuable time in doing an MRI. We are easily wasting another 20 to 25 minutes, maybe even longer, I don't know. To prep the patient for an MRI and to do, everyone says that MRI can be done in 10 minutes, but to prep the patient also takes 10 minutes. So, you wasted those 20 minutes. So I am a great advocate of, when the person is in the window of 3 hours or 3.5 hours or 4 hours, go ahead. Nothing happens. And, we are worried about large infarct and all. Yeah, that worry is there. But, the benefit far outweighs the risk, And if IVT works, wonderful. If it doesn't work, go ahead with MT. But I would very much favor doing IVT before MT. Of course, the interventionalists always fight with me. And they say, no, you must do MT. But, there is no trial which has shown, no trial has shown that the MT, direct MT is better than IVT followed by MT. In fact, there is a signal to show that IVT followed by MT is better. It's not yet in statistical. It's not yet come up to statistical level, but there is a signal. And in a resource poor country, if you can open the vessel in even 20% of patients, you have saved a lot of money, a lot of time, a lot of effort. So I would certainly think that I would have done it this way. But whatever you have done has worked beautifully. And so no, I mean, no comments on that. It has worked. But I think this is what I would have done. And of course, you must screen this patient for LA thrombus. You should screen this patient for AF. I think probably she had AF because, bioprosthetic valve, such a big clot, to go, it must be a large dilated LA. Did you do the echo?
Yes, sir, echo is done.
What was the LA size?
LA size was normal. They have mentioned nothing about the LA LV clot. We asked for specifically for that, but our cardiologist says there's nothing like this. So
yeah, but I would certainly anticoagulate this patient. Which one, NOAC or warfarin? Maybe warfarin in this case.
Yes.
What do you think, Pramod?
Yes, sir. We'll go with vitamin K antagonist.
Yeah. Because the SMS, you think she probably had AF?
Most likely, sir.
Yeah.
Might be one of the things which get missed is that we do a transthoracic and come out.
Correct.
So this is an ideal case for doing a TE and looking at it.
Yes, yes. You must do TE freely. So you'll be amazed at the amount of information you get. You said the valve was not working and valve had to be replaced. I mean, why did they take that decision? That I think maybe you could clarify. But use TE freely. I mean, it's not a major investigation. It's a routine thing. And you'll be surprised how many times you see an LA thrombus. You can see the LA appendage. You can measure the size of the left atrium. You can see the mitral valve so much better. So T, I think, should be done in this case. And maybe, I think, yes, warfarin is... VKs are definitely indicated because such a large thrombus will not come, which will not be a platelet thrombus. It'll be a clot. It'll be a proper clot, and the density also, which was seen on the CT scan, was pretty high. It looked like a clot only red thrombus, not a platelet-rich thrombus. So definitely anticoagulation. Parul?
So cardiac MRI also would be done.
No, I think T is better. Cardiac MRI is good for, cardiomyopathies and infiltrative lesions of the myocardium. It's not easily available. Interpretation is always in doubt. So I think best investigation here would be a T. Of course, transthoracic Doppler, of course, you should do, but do the T freely, because it gives you a wealth of information. And so maybe I would little bit vary with the treatment that we would give. What do you say, SMS?
Yes, sir.
Would
Sir,
you give IVT?
I would have given IVT, sir, because I have two studies also to quote Dr. Pratik.
Yeah.
The first thing is that when we talk about NIHS more than 21 being difficult for us, it was based on the original NINDS2 data. They had a certain criteria to go out and do a study. For that purpose, that was devised so
Correct.
that they would not choose a very severe patient for us. But in 2014 also in Lancet, there was a publication which showed that what is the role of the severity of stroke in determining the outcome. That was based on NIHSS only. While it was true that higher the NIHSS, you will have more chance of hemorrhage. It was also noticed that while that is true, the outcomes did not differ at all based on severity. And secondly, even if you look at the Bruce Campbell's data, Extend IATNK trial, you will be clearly seeing that these are the patients who had large strokes only. There only it showed that selective planes open more than 10%. The often quoted data comes from large vessel occlusion only. Which means if it is a large vessel occlusion, the corollary is that the NHS should have been high in these people. So we are all very fond of IVT first. And in fact, it gives easy access for our interventional radiologists to go in because it somewhere clears the clot, and cardioembolism sometimes even disappears without it. We all know the vanishing heart syndrome also. So when these things are there, I would have been liking to go with IVT followed by MT in this. But that would have been my personal choice. However, you are in the playing field, so you are correct.
Yeah, I fully agree with what you say. Even these severe strokes, if you see the data, severe strokes also do better with IVT than no IVT. Even though the risk is higher of bleeding, because anyway, they would have not done well. Severe stroke with an age of 25 plus would not have done well had you not given. So had you given, in fact, they have done little better than had you not given, in spite of the increased risk of hemorrhage. Even if you factor in the hemorrhage, they do better than had you not given. Of course, there's an initial burst of mortality because of hemorrhage. But if you see 3 months down the line, they have done better. So, Pramod?
Yes, sir, I fully agree. And probably it's also possible that with the current tenecteplase use, the probability of hemorrhage is also a little less compared to alteplase. It's more fibrin specific, so we see less hemorrhages compared to alteplase. So a safe option in this child, and he's also adolescent, he's near adult, he's 15 years. So I also thought that IVT followed by mechanical thrombectomy would be the same. Only thing is when you're outside the guidelines, we need to do talk maybe better documentation and talking to the family so that they understand what we are doing. So if there is a strong reluctance from them, then that's a different issue. But most of them would go with our advice.
You know, Pratik, if you really wanted to do the MRI also, that's okay. But you know, you could have given the IVT in the CT scan department and then done the MRI. Because then you have saved those 20 minutes and you don't know what has happened that damn clot could have just been obliterated. You never
maybe
know
after
what could have happened.
after this 30 minutes of my brainstorming season, I will do this the next time. So
Yeah, I
that
think
maybe
so, because, we are
1 year back.
frightened. We are abnormally frightened of IVT, which I think, we should not be.
Because
And we are frightened. I mean, I'm frightened all the time. But I think we have to overcome that fear, because the benefit is so drastic. And though there have been many, many very vociferous, uh, what shall I say, vociferous people who say, no, 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 IBT should not be given and this and that. But it has not stood that type of argument has not stood the test of time. Now it's 25 years since IBT has come, and this argument has not stood the test of time. So, okay, in an individual patient, you are scared. But if you see the data, the risk is minimal. So maybe we could do that. But I must congratulate you on the good work done, and you've saved this little girl's life. And obviously it came in the newspaper, and you became a hero to the family, and which is a very, very, very nice thing to happen. And these type of cases will, and instead of sitting in our rooms and just talking, if it comes out in the press, and the people in the community get involved and inspired, and other doctors get inspired, this whole stroke thing can really take off. Otherwise, we are stuck with, people not coming in time, GPs refusing, many times the family wants to talk to their doctor, and their doctor doesn't know about thrombolysis. And he says, no, 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 don't give. But he doesn't know, man. He doesn't know what is, and on what basis do they say no? So, so publicizing this in the press, I think, is very important. Publicizing it in the community. You should tom-tom it. It is not advertising. It is giving knowledge to the community. I think that is very necessary. And I'm very happy to see that it came in the lay press, and people, hundreds and thousands of people must have read it. And this stroke awareness grows, and people can come in time, and we can help many, many, many more people. So no use just sitting in your air-conditioned rooms and writing prescriptions. We must go out into the community, and we must talk to local politicians, local press, local leaders, local gundas, all these fellows we must talk to, and make this popular. So, there are so many people, who want to say no, no, no. But, we have to cut that. It's 25 years, and still we have not been able to, increase our rate to more than 5%, 10%. So I think this publicity part, it's not advertising, Some fellow will say, no, no, you are advertising your center, and you're trying to get, there will be people who will say that. But it's not advertising. It is giving knowledge to the community. What do you say, SMS?
Completely agreed, sir. We should, sir.
Yeah, yeah,
Because
we should involve the local people, And what I find is, local doctors, they oppose, yeah. They oppose, I mean, first of all, they don't know anything about it, but they want to oppose it. So we have to break through this. So this publicity, I think, is very important.
I do one simple thing, sir, in
Yeah,
emergency.
yeah,
I start the moment I start talking to them, I ask them to take a record of me, video. And there I tell them that 1 minute, 19 lakh neurons die.
yeah.
Now you give me the time. Sir, whenever you tell me, yeah, I don't know, I'm not going to tell you anymore.
Yeah.
You tell me whomsoever you talk and come back to me. Now the time is on you. The switch, the clock is on.
Correct. Yeah, so
And
tell
they,
them that many people you talk, so many neurons will not be there.
and then second thing, what Balmurugan taught me, sir.
Yeah, yeah.
Balmurugan taught a beautiful thing for all of us to counsel. I think it's a good thing to share in a forum for people to say. When people say, "If this gives, will it cure? Will my father come back to normalcy?" These are the questions they ask. So Balmurugan has a very beautiful way of putting it forward. He says, you have to tell the family that your house is on fire. The
Yes.
fireman is trying to enter. Now there are two choices for you. You tell the fireman, look, if you go, you must get all the documents out. On the left top compartment, there is my money, everything should be out. The jewels are on the third floor, everything should be out. And all my clothes should be out, my everything should be out. If it is possible, you go inside. Otherwise, don't go inside. Have you ever spoken like that? Your house on fire, man, you just go and get whatever you want. That's what we are doing. If we are firefighting, you take it or leave it. Believe me, sir, I have used it in
Very
all
good
my
method.
patients
Very
after
good.
that.
I'm going to use it next time.
100% success, sir.
I'm going to use
Balu's credit, sir. Salem
You
Balu's credit.
always come out with some gem, SMS.
He taught me, sir. He has written a book also for that.
Yeah. Pramod, any
Yes,
last
sir.
comments on the case?
No, I just wanted to commend SMS sir for that gem. So it's a good way to get the
He is
message.
full of these
Balamurigan.
gems. He's full of these gems.
Balamurigan, sir. Balmurugan. Yes.
Yeah, Bala said this, no? Yeah. Parul,
Balmurugan.
Parul,
No,
any last
yes,
comment on
sir.
this case?
No, sir, I agree with the entire discussion. IVT first.
Huh?
IVT first,
Okay.
then go for MT.
Yeah,
Yes.
yeah. Okay, Dr. Pratik, thank you so much. And well done. Congratulations.
Thank you, sir.
And many more successes in the future.
Okay,
Of course, there will be few failures, never mind, but more successes than failures. So,
thank you,
well
sir.
done.
Thank you, sir.
Now, may I invite Dr. Varun?
Thank you, sir. I'll just share my video.
Yeah.
Presentation. Are my slides visible, sir?
Yes, very well.
I would like to thank Emcure for giving me this opportunity again to present at this esteemed forum. I would like to thank our moderator and our chairpersons, Dr. Chakuria sir, Dr. Meenakshi Sundaram sir, Dr. Pramod sir, and Dr. Parul madam. And we'll be discussing this thrombolysis case that we did in a high-risk patient. So this case was a 51-year-old male who was a known case of dilated cardiomyopathy with a low ejection fraction of 20%. And he was recently admitted under the ortho department for fracture of the right tibia and was operated by open reduction and internal fixation 6 days prior to the event that had happened. So on the 6th day of post-operative day, he was noted that he was having altered behavior. There was a left hemiparesis and there was a drooping of both eyelids at around 8 a.m. At the time of onset of ictus, he was in the HTU, he was in the recovery unit and had an awakening at 6 a.m. and had requested for water. The patient was clinically examined by our junior resident on call and findings were observed by a resident on call. So as a protocol, since we have junior residents, so it is always videographic evidences is always documented by us and we call for videos by the JR. So It was noted somewhere around 8 o'clock when the sisters were having their change of duty that the patient had become drowsy. And it was then when the JR had seen the patient, was these things were the examination findings noticed. So I'll run the video. So as we can see, he's unable to open his eyes. He's a little confused. His speech is a little slurred. Although the commands given by the doctor were not clear on pointing out to the right arm and the left arm, but seeing the event, the JR was probably with new in his duty, but he did still a good job in documenting that the patient was having a left upper limb weakness as well. The second part of the video. So he was drowsy. He was not moving his left leg. The right leg movement was not documented because it was fixated. So whether the patient was having a left hemiplegia or was it a quadri with a asymmetrical presentation with ptosis? So was it? So we were a little confused at that at the time when I had seen the video. So the onset was at 8 a.m. The last known normal was of 6 a.m. and the NHSS was documented to be around 11 for this patient. So, was it really stroke or is it encephalopathy? That was the first doubt that I had in my mind. And if it is a stroke, where is the lesion? Etiology probably if it is stroke, then it must be cardiomyopathy considering the dilated cardiomyopathy. But the issue was if it is going to turn out to be a stroke with a recent surgery and patient being on DVT prophylaxis, would I be able to thrombolize? So while I was thinking about what imaging to do, I was also looking ahead. If it turns out to be stroke, then what I have to do? So obviously, with the doubt in mind, I ordered first for an MRI to be conclusive and to be sure that it is a stroke. So the MRI was done at 8:28 a.m. Within it took us, as Dr. Chapuria said, it appears that it could happen in 10 minutes, but it takes time. So we could mobilize the patient, and by 28 minutes from the call, we were able to get the MRI. And as we can see on the diffusion weighted images, a small speck of altered signal intensities were noted in the cerebellum. It was noticed in the midbrain and in the bilateral median, paramedian thalamus areas, and it was also showing subtle flare positivity. The angiographic images suggested no evidence of large vessel occlusion. So, the doubts that we had in our mind, since the patient was within the window period, the patient was whether patient should be considered for IV thrombolysis or not. The problem was the recent major surgery that the patient had, which was just 6 days back. The patient was on a prophylactic dose of the anticoagulant. However, he had received at the night because the usual anticoagulation that was being given was as HS 10 p.m. So he had received at rather 10 p.m. the previous night, and the subtle flare positivity that he was having. So, as we know that whenever we thrombolize our patients, the standard thing that we tell our patients is that it is more than 95%, 90 to 92% safe. However, there's a 6 to 8% chance of complications, including bleeding. However, with this case, the risk of bleeding would have been higher, and this was cautioned to the team, and the ortho teams was also involved, and they were told about the risk of bleeding, and they would say that if there would be any surgical site bleeding, they would be able to tackle with it to a drain or plan accordingly. So, with the high risk of bleeding, consent was taken, and patient was thrombolyzed with tectase injection 0.25 milligram per kg at 9:15 a.m. So it took around 40 minutes for us to come to a conclusive diagnosis because of the complexities of the situation. So by the end of the second day, patient had improved in his NHS score, and by the time the patient was discharged, he had made a major part of recovery of his deficits. However, the deficits of a little poor attention, mild left upper limb weakness, and mild ptosis continued to happen. So this is not the discharge video, but this is the video uh, of the Second day, so as we can see, the consciousness is a little better, alertness is better, his doses is better. The vertical gaze was affected, especially the up gaze. As he's not following command in this case, but if you can notice, he was holding the railing with his left hand and he was able to lift it. The power had improved to grade 3/5. So even with the push, he's not lifting it, but he has definitely improved in his power. So this was the repeat check CT that was done. This is actually the base images of that, of the angiographic images that were done later. Complete NCCT head and CT angio was done. I didn't have the CT images, plain basic CT images, and there were no evidence of hemorrhage. The patient was documented to have on Holter runs of AF, and the patient was discharged on the NOAC, Sapinsavat, aspirin, and torvastatin. And a diagnosis of artery of Percheron cardioembolic infarct was made in this case. So coming to a brief discussion. So whenever we have the involvements of the bilateral thalami, the possibilities are of artery of Percheron infarct. There could be possibility for top of basilar artery infarction also, but as we know, they usually have involvement of the cerebellum and the occipital lobes. Deep CVT and infiltrated neoplasms of the thalamus are the other possibility that have to be kept in mind. Usually, we know that from the PCA, there are perforators supplying the thalamus and the midbrain. However, the artery of Percheron may arise as a unpaired trunk from the P1 aspect and we supply bilaterally and usually presents with a triad of vertical gaze palsies, attention deficits, and memory deficits. The usual ischemic patterns of these infarctions are involving of the bilateral paramedian thalamus with midbrain or without midbrain, which is the two most common findings. And in our case, as we can see, it will involve the thalamus and the midbrain. This one has usually the poor prognosis. However, in our case, the prognosis was better. We were able to intervene and provide good result in this case. And the other possible is the bilateral paramedian thalamus involvement without the midbrain involvement. These are the common two most spectrum of the bilateral of the artery of Percheron infarction. So now coming to the caveats that we had. So the first caveat was the recent major surgery. So it has been documented, as per the guidelines, it has been suggested that with if this patient has undergone surgery within 14 days, then these alteplase, the surgery, the IV thrombolysis can be considered, but there's a potential increased risk of the surgical site hemorrhage, and it should be weighed. It has to be weighed against the risks and benefits of the stroke-related neurological deficits. And as per the ESO guidelines, it stated that if the patient is having an acute ischemic stroke within 4.5 hours and with a major surgery of a non-compressible site where bleeding is likely to lead to a significant hemorrhage that is involving of the abdomen, chest, skull, well vascular tissues or the large arteries during the preceding 40 days. In these cases, they do not recommend since this was a compressible site. So the risk can be still taken if the deficit is significant. So the second issue that we noticed was that the LMWH. So whether with the LMWH being given, should we thrombolyze or not? So as per the guidelines, it was initially said that if the patient has received full treatment dose of the LMWH over the past 24 hours, then the patient should not be thrombolized, but this does not hold to the prophylactic doses. So if your patient is on DVT prophylactic doses within the previous 24 hours, then you can still thrombolize your patients. Next, coming to the third caveat that was in my mind, that is the diffusion and flare mismatch. So as we know that the flare positivity usually turns around somewhere between the 4.5 to 6 hours, but sometimes it may come in even by 5% in the first 1.5 hours. So diffusion flare positivity, I would suggest what I have seen is that it may not be a good marker if you know the onset. If, however, you're not having the onset, then you may use it as a surrogate marker to try and predict the onset. So we use TPA and as we know, time is brain, and as early as we thrombolize, the NNT is better, and it has better fibrin specificity. It has a higher affinity to the plasminogen activator inhibitor, and a four-fold prolonged plasma half-life. So the learning points, according to me, was that we should remain updated. We should know it was that the lower molecular weight heparin dose has been changed from 2015 to 2018 and forward. That the prior administration of LMWH was restricted only to the therapeutic dose and not to the prophylactic dose. We need to be thorough with regards to our topic, and we should always be uh, in loop with our attendants and the relatives, that they should know that what we are doing, and we should always tell them that the risk of bleeding can be higher in certain cases, but we should always offer them the best possible treatment. And the learning points for me was that we should, the guidelines are obviously there to help and guide us, but they should be adhered, and they have to be adhered for the medical legal purposes, but we have to go case by case, and sometimes we have to take difficult calls, and sometimes we have to follow our gut instinct and take the best possible therapeutic decision for our patients. Thank you.
Yeah. Hi, Dr. Pramod here.
So
So I would say uh, a very brave decision. I would not
So-
have taken this decision. I would
So-
have been very concerned about the recent surgery and the risk of bleeding and ruining the surgery. So I would have been very apprehensive to go ahead with with the thrombolysis in this patient. Are you sure about the onset time? Because since the flare changes have appeared, we
yes,
are
sir,
very
because it has been documented that when the patient had woken up and the night duty shift sister, she had personally given the patient a glass of water at around 6 a.m. And then when at around 8 a.m. they had a change of duty, they noticed that the patient was drowsy. So we got the call that the patient has suddenly become drowsy.
okay.
So we know that it was so.
All right. Yes. So I think the risks here of bleeding is very real because it's just a 6-day-old surgery, isn't it?
So,
Did you do a MR angio since you went into the MRI machine? Did you do an MR angio just to see whether there was a basilar?
so yes, sir. Sir, I had shown the images. The fifth images, the last image was
Okay.
the MR angio. The basilar was normal, sir.
Normal. Okay. Okay. So I think if a similar situation comes up, it's very difficult to take this decision to thrombolize when somebody has been operated and that to an ORIF. Of
So,
course, maybe the orthopedics are confident, but they may not anticipate the kind of bleeding that might happen also.
so,
So it's definitely a huge risk. You took it, it paid off, but I don't know whether it can be replicated.
so.
Parul,
Yeah, I would agree with Pramod Krishnan, sir. I would be quite scared of thrombolizing such a patient, uh, particularly because the surgery has been done very recently. He has received anticoagulation, whatever dose, of course. Yes, I would be. And previously, that is also because of my experience. Like two patients, I was just in the last case, post coronary angiography, they had a stroke, of course, in almost within 15-20 minutes, we were told, and I thrombolized them, and both of them died because of the hemorrhage. So, yes, I would agree that probably replicating this is a little high risk. It is like you have to see in every patient how it works because there are many things. Because once they bleed, sir, and patient dies, then it's very, very difficult. If the results are good, good.
SMS.
Sir, what is your blood pressure?
Sir, the documented vitals were no.
No,
Can you
no,
hear
no,
me,
no,
sir?
Dr. Varun. I'm asking
Sir,
your blood pressure. See,
sir,
they
at
say
that
that
time,
stroke
it
stroke
was
increase.
very difficult for me because
Mm.
I am with Dr. Rajiv Anand, and he was my senior faculty with me, but sir was not available, and I had to take this decision on my own. So the onus was completely on me. My blood pressure was definitely shooting. The patient's BP was okay.
Because they
So
say, no,
yeah,
they say stroke increases the blood pressure of
so
the patient and the doctor. So
so
this is one typical example, I think really it is a
yeah,
tough call to take. But there
yeah,
is some
yeah.
literature about post-operative stroke. It came in one of the discussions in other forum. So these
Um,
post-operative strokes, whether we should thrombolyze, because the initial NINDS was at least 3 months. That's what sir
mm,
was saying. But there have been patients who have been done with thrombolysis in the post-operative setting. In fact, thrombolysis is done in a patient who has undergone carotid endarterectomy. So many things have been, I don't know, more than 100 patients have been published. So what this data showed is that the stroke, when it happens within 2 weeks of the surgery, then that is a higher risk for us. As in this case, as Pramod sir was saying, 6 days, it is difficult. However, this data clearly said, even in these patients, the hemorrhage risk was not too high. The data is available in Stroke Journal. 2017 was published. Only the risk was around, I think, around 6-7%. That is all. And 3% of them were serious hemorrhages. Fortunately, there was no fatality. So this we try to take it and put it across in a given patient. They don't agree for this. I mean, even the treating surgeon doesn't agree for this. He told me, I only call it to give an opinion and not this opinion. You give me another opinion for me. That's what the surgeon would say. But you are too lucky, because this is a case where if bleeding happens into the posterior circulation, brainstem, because there was signs of midbrain involvement is showed. So there, then it would be a real trouble thing for us. But it was a brave decision, as I was saying, and you're supported by literature at least now. You're right in that. Good to go. Congratulations.
so thank you, sir. So probably we were able to able to talk it out with the orthopedics because he had already had a fracture of the right leg and now the left leg was gone. They were thinking about mobilizing the patient and the normal leg had had the stroke. So they were thinking about having their good surgical results and we were thinking about whether we thrombolize and or the patient is going to have bleed. So it was a chaos at that time, but somehow we were able to come to a conclusion and it was good for the patients.
Also, the evidence that is there, no, it's all very weak evidence. They're all the strength of recommendation is low. The evidence strength is also weak. So uh, it's very risky in such a situation. And if things go wrong, then defending the decision might become very difficult. So I
So,
think you must have spoken very well to the family and
so,
the other teams for them to
so,
have finally given the green signal, because
so,
this is too difficult a decision to take. And I would have
yeah,
backed out. I would have not had the
so,
courage to thrombolize this patient.
yeah.
You're waiting for Nasli sir to tell, sir, would you have thrombolize or not?
But Varun, I think you've done a fantastic job.
Thank you, sir.
I would have thrombolized. I'll tell you why. You know, my philosophy is find a reason to thrombolize and not an excuse not to thrombolize. That is my philosophy. I mean, see, now what is the evidence? The evidence says that if it is a thoracic surgery or abdominal surgery or genitourinary surgery, there has been no trial. There has been no trial to show that you should wait for 14 days. This is just a safety measure which has been incorporated into the guidelines. Nobody has done a trial. Now, this thing is a tibial fracture. Okay. And the wound is relatively okay. You have given Clexane. In orthopedics, we give DVT prophylaxis within 24 hours or even within 12 hours. So we are giving DVT prophylaxis. It is also a compressible site. What is going to happen? Okay, he'll bleed there. No, he'll bleed in the tibia. You can evacuate that clot. The fracture is not going to non-unite. He's not going to lose the leg. So it is a compressible site. So if it is a non-compressible site, like say a bypass has been done, or some abdominal bariatric surgery has been done, or some kidney transplant has been done. Okay, those cases I would not give. But this is a compressible site. ठीक है. If he bleeds, okay. He may bleed. Of course, he may bleed. You compress that part and you drain that hematoma if it is there. Is it going to destroy the fracture? It's not going to. Secondly, so therefore, looking at all this, there is no guideline which says that non-compressible site you should not thrombolize. This is only for genitourinary, abdominal, and thoracic, or maybe eye surgery, some vitreoretinal surgery, or some brain surgery has been done. Okay, you can't compress those areas. Obviously, you will not give there. But this one, I think I would give. I know I'm a little bold and, people don't agree with me many times and they fight endlessly. But this is what I strongly feel. Secondly, when it is 3 hours and 3.5 hours, there is no point in doing DWI flare mismatch. This study of the wake-up stroke trial was done when the unknown time of onset. Here we know the time of onset. So don't go by that. Don't go by that. Because then, you'll think that, arey, flare mein dikh raha hai thoda, you can see a little bit, so therefore don't thrombolize. Arey, where is it written like that? This fellow has come in 3.5 hours, intra hospital stroke. He's well within the window. He's in 3.5 hours. So there's no point in doing till 4.5 hours. There is no point in doing diffusion flare mismatch. You're just confusing the issue, You're just confusing. And then, you get that doubt in your mind. Should I do or should I not do? There is no data to show that you should do. The thing is when the time is unknown or it is a wake-up stroke. That time you do. Of course, that is in the guidelines. It's a weak guideline. It's not a very powerful guideline, but it's there. So respect it as much as it possible. But 3.5 hours, 4.5 hours, you don't need to do it. Secondly, I used to get very worried. Many people used to give Clexane and send the patient. The patient got a stroke and they would give Clexane subcutaneously and then send the stroke. So, in the initial part of my career, I said, no, I'm scared. I'm not going to do it. But it's very clear that prophylactic dose of the LMWH is not a contraindication. So if it is a therapeutic dose, yes, maybe you would not give. Yes, you would not give. But this is a prophylactic dose. And now they have very clearly said that if it is a prophylactic dose, and usually they give 0.4 ml. How much was given? 0.4 or 0.6?
0.4, sir. 0.4 was the dose.
So it's not even half the therapeutic dose. So it's 0.4. It's given 12 hours. 12 hours, is it? 9 hours, 10 hours before.
Yes, sir. 10 hours before, sir.
Yeah, so it's already waning a little bit. It's not at its peak. So I think that's not really a contraindication. Then, which was the other? So that flare mismatch thing is not a contraindication. This compressible site is not this thing. And this looks definitely like a Percheron artery cardioembolic stroke. And he's a prime candidate for that because he's got cardiomyopathy and he had AF, very clear AF. So it is, though it's rare, for a small embolus to go into such a small artery Percheron, but there is a small little infarct also in the cerebellum.
Cerebellum.
Yeah,
Sir.
and the vessels look normal. So normal looking vessels and two different sites of infarct is very likely to be cardioembolic. And very clearly we have shown AF. And even if we had not shown AF, cardiomyopathy is there. So, and of course, post-operative period is a risky period because maybe this chap was on aspirin in the beginning and the surgeon stopped the aspirin. And, during the surgery also, the procoagulant state is there. The dehydration is there. Fibrinogen levels go up. So post-operative period is a high risk period for stroke. So And he has all stroke risk factors. He has cardiomyopathy, he has AF. I don't know whether previously he was on anticoagulant or not, and maybe the anticoagulant was stopped. We don't know. So, was there any history of anticoagulant in the past
No,
before
sir.
surgery?
No, sir. No, sir.
No, not known.
No.
But he
Only
was
on
a
an aspirin.
known cardiomyopathy.
Yeah. Yes.
So his LV function was poor. So he was
Yeah.
he was a good candidate for getting a stroke. So, and perioperative stroke is well known. Of course, it is more common with cardiac surgery and carotid artery surgery, but it can occur with any surgery, abdominal surgery. This chap is only 51, so he's not very old. He's in bed, so the circulation is also poor. So this is a classical perioperative stroke, and I must congratulate you for. I think I would fully agree with what you say. I don't agree with Pramod. Sorry, Pramod, but you be a little bold. And the thing is that if you read the guidelines again, it says non-compressible site, and it says abdominal, brain, thorax, genitourinary. But if it is peripheral, say a corn is removed, or some pile surgery is done, or some thing like hydrocele is operated, you can give. And what's going to happen? It's going to bleed a little bit there. Press it now, yeah. Just put pressure on that tibia and maybe drain it. But nothing happened, Varun. There's no bleeding.
No,
which
sir.
happened
Nothing.
in
Nothing.
the
Nothing
tibia.
happened.
Yeah,
No,
nothing
sir.
happened. So, and these wounds, after 2-3 days, they heal. And, we are giving LMWH within 24 hours, even 12 hours. So, in fact, we should give because, DVT is so high in these patients. So, I fully agree with what you've done, Varun. Congratulations.
Thank you, sir.
Very.
Thank you.
And, you know, I don't seem to remember that I've thrombolized a percheron because they usually come a little late, but this was intra-hospital, so you had that
Yeah.
advantage.
Yeah.
But
Even
you'll
for
be
this, the code
surprised.
white was not. So the code white was not announced. It was a regular call that the patient had suddenly become drowsy.
No, so that
But
is the
still,
thing,
yeah.
the surgical people are not aware of stroke
So
and they cannot
yeah.
diagnose stroke. So if that
So
orthopedic resident went there, he must not have. I mean, it's difficult for him also to, and
yeah.
it is to his credit that he diagnosed stroke.
So
Many times it is missed, and 6-8
yes.
hours later, it's happened to me many times. This
Yes.
intra-hospital stroke has been missed by the nurses and
Missed.
the residents because they are
Yes.
surgical residents, orthopedic residents.
So
अभी orthopedic को क्या neurology मालूम ही नहीं है यार कुछ. They don't know any neurology. Sorry to say, but they don't because they are attuned to something else. So it's good that at least 2 hours later it was diagnosed.
yeah. So
Yeah. So that code stroke was not called, no? It was
yes,
a
sir.
routine call.
It
So
was a routine call.
yeah, the patient must have been in an orthopedic ward or HDU, you said, no?
Yes, sir. He was in this surgical HDU recovery unit.
He was in. So the surgical HDU people, they are not tuned to medical cases.
So
So therefore I feel every time, even a surgical case should be admitted under a physician, especially these high-risk fellows with cardiomyopathy and this and that, so that's what I feel. Parul, I know
Yes,
you
sir,
don't
after
agree with me, but it's okay. We can
no,
always
sir,
disagree.
after
Yeah, you're my good friend, so we can disagree. We can fight. It's no problem.
yes, I would have done it. Very brave of Dr. Varun, and you are the bravest thrombolizer.
But see, nothing happened. But that doesn't
Yeah.
justify it. But the argument justifies it. I mean, that nothing happened. We can say he was lucky, but he's not lucky. I think he made a good calculated decision. I mean, he made a good.
Yes.
I mean, see, you have to weigh risk, and it depends. You have to weigh it, and he got away with it, and the patient benefited.
Yes.
SMS.
Yeah, it's
Completely
a
agree with
So I have learned two things.
commendable decision making under high pressure.
Yeah.
So,
But luck
with
favors the brave, yeah.
yes, so
Luck
it's
favors
really,
the brave.
really brave and well thought out and well argued in the end, because I mean, there are justifications for each step and for each of those
Yes.
so-called difficulties. He's identified that there's an argument around it. So I think that is truly commendable. And regarding the in-hospital stroke, we had a study. They tend to get missed so much because some of them are encephalopathic to begin with. So if something new deficit happens, people don't notice it. And very often the treatment also is delayed because sometimes they're too sick to be mobilized for relevant tests. And we have seen that in-hospital strokes, they have longer diagnosis times, sometimes longer treatment times also, especially if there's sick patients in the ICU. Very often the sisters don't pick up the deficits at all. They don't realize, they just do the GCS and leave it, and they don't notice what happens.
Exactly.
So here the patient is lucky that he got diagnosed on time, and he had a brave doctor to take a very difficult decision on his behalf. So congratulations.
Yeah, so we learn so much, huh? We learn so much by these cases. So we become better and better with each single case. So congrats once again. And I think we've discussed it through, no? Anything else you all want to say? SMS?
In this case, sir, yes, in this case, he did MRI because as Pramod sir was also saying, the diagnosis of stroke was not apparent because anterior circulation, we are easy to pick up that one side is not moving. Here, one patient has been operated on one side, both side fractures. He is also not, fully conscious. So he was with the decision, and we have to quickly assess because we have to do something for the patient. And there is a pressure. The surgeon will be sitting on the neck. Hey, what is happening? Give me the answer right now. And then we have to take quick decisions, probably to make it easier, I think, with an MRI. That's the reason why you did
But
MRI.
it's
Correct,
good.
sir?
Yes, sir.
It's good
So-
the radiologist did not object. There's some metal in the body, and therefore we won't do MRI. That is another big headache. So half an hour goes in that argument. Yeah. But probably it was non-magnetic, no? Whatever those
Non-magnetic, yes.
Yeah, non-magnetic.
Yes,
so you have to know that it's non-magnetic. So you have to ask the
Yes, sir.
surgeon, "Are kya dala hai? Have you put in some magnetic substance or non-magnetic substance?" So again time goes in that. You have to phone him up.
Yeah.
So did you do that, Varun?
Sir, since I had received the call for encephalopathy, I had initially ordered for the MRI.
Ah,
So by the time I saw the video, I thought that it is probably stroke, it's not encephalopathy. So
yeah.
then I cross-checked with the orthopedic team, is it safe or not? And they said, go
Yeah.
ahead.
So
And
you
then
had to
when we
take
got
that
to
step,
know-
no?
Yes, sir.
I mean, you had
And
to
then when I
talk to
got
the
to know that,
orthopedic.
yes, sir. And then when we got to know that it is bilateral thalamus, I told him that we are probably going to lose this patient. He's going to land up in coma. And then he was also brave enough to take the decision that we can't lose the patient. Absolutely. So we took that.
Yeah. So I think we've had a great meeting, 2 great cases, lots of learning, lots of take-home points. And I think we've become wiser, bolder, better with all this discussion. So, Namra, can you sum up and close? We are already, as usual, running late.
Yeah, okay. So thank you, Dr. Richa Poria, sir. Thank you so much for the time that you have provided us for the meeting. And we are extremely grateful to you for the same. Also, I would also like to thank Dr. Pramod Krishnan, sir, Dr. Parul Dubey, ma'am, and Dr. Meenakshi Sundaram, sir, for the wonderful clinical insights that you have provided us with. Also, our eminent speakers, about the case discussion. It was an educational feast to learn about the different cases which you have handled and taken brave decisions and commendable ones. So it was a pleasure to know everything, and I would like to include this point that we had 320 attendees for today's session.
How many?
320.
Oh, that's a good number.
Yes.
You think so many people are interested in stroke, huh?
Absolutely, such great speakers with such great course directors and moderators. Why wouldn't they attend?
But anyway, 320 is a good number, and I'm sure they've benefited. Any questions from them?
No, sir. No questions.
No questions from them.
No.
Okay. Okay. So thank you. You can sum up and.
Yes. So soon we will be meeting for another discussion on such wonderful cases. Until then, thank you, everyone, and good night.
Good night, everyone.
Thank you so much. Good night, sir.
Thank you, sir.
Good night, everyone.
Thank you,
Good night.
Pramod sir.
Thank you,
Thank
sir.
you.